Move on quickly to the next session. Next session on breast improving outcomes through advanced learning. May I invite the chairpersons for the session, Dr. Dayananda Babu, Gokula Medical College, Trivandrum, Dr. Sri Kumar, P.K. Das Medical College, Dr. T.V. Murli, Surgical Oncologist, GMC, Kottayam. And the speakers, may I request you all kindly to take your seats on the dais also. Dr. Sulfiker MS, Additional Professor GMC Kollam, Dr. Shafiq Shamshuddin, MVR Cancer Center Calicut, and Dr. Vijay Kumar, Professor HOD Department of Breast Gynec Oncology, AIMS Kochi. First speaker, Dr. Sulfiker. I'd also like to call on Dr. Jency Joy, Associate Professor from Tiruvalla, Associate Professor Surgical Oncology, PIMS Tiruvalla. So I'd like to bring to attention of our chairpersons that Dr. Jency Joy will not be presenting today. Over to Dr. Zulfikar now.
Good morning, senior faculty members, friends and students. Today's my topic is fibroadenoma, when to operate. First of all, I would like to thank the organizers for giving me this topic. This is important because such a question usually it will be there in the minds of junior most member in the surgical team. So this topic is very relevant in that aspect. So when to operate? So let us start with a clinical scenario. This patient, 52-year-old female patient, presented with a screening mammogram report, saying that there's a small, smooth-walled hypoechoic lesion of size 1 into 1 centimeter into 1.2 centimeter in the right breast. You can see the lesion there. There's an impalpable lesion, not palpable on deep palpation also. We send the patient for ultrasound guided FNAC, which showed benign fibroepithelial proliferative lesion. They reported as suggestive of fibroadenoma. What will you do for that? Before giving the verdict, is it a neoplasm? That is the first question. Fibroadenomas are not considered as neoplasm, but hyperplasia of the lobule. Considered as aberration of normal development and involution, and most common cause for breast lump in female aged 15 to 25. This is supported by the following facts. Like fibroadenoma developed from a single lobule, not from a single cell or cell group. It closely resembles hyperplastic lobule seen in normal breast. It shows same hormonal dependence, and they are hormonally responsive also, demonstrating hormone dependence during both the menstrual cycle and pregnancy. Later it will regress, it may involute to hyaline connective tissue in the older age group. Second, ND classification of benign breast disease. It's a disorder seen in early reproductive age between 15 to 25 years. This chart also shows the importance of age. It is peaking between 20 to 25. Next question is it a hematoma? Again, some older books says that it is a hematoma, but that is also not correct. It is not a hematoma. Hematomas are benign tumors of the interlobar stroma, but fibroadenomas and phylloid tumors originate from specialized intralobular stroma. But suggested etiological factor, one thing is developed due to the increased sensitivity of focal area of breast to estrogen. Some areas are more sensitive. Fibroadenomas are benign solid tumors composed of stromal and epithelial elements, so generally considered as biphasic tumors. May present along with fibroadenosis, and sometimes can be multiple or bilateral. In around 10 to 16% cases can be bilateral also. There are various types. Typically we see typical fibroadenoma or classical fibroadenoma in younger age group, but there can be juvenile fibroadenoma, which refers to occasional large fibroadenoma with a relatively increased rate of growth. seen in adolescents and younger adults. And histologically is more cellular than usual fibroadenoma. But important fact is that is not associated with English stands for malignancy or ATPM. Next terminology is giant fibroadenoma if the size is more than 5 centimeters. And rarely there can be myxoid fibroadenoma with pathological features of myxoid connective tissue there in between, seen in Carney's complex. Some points about pathology. Microscopically shows proliferation of epithelial and mesenchymal elements. Also, the cytogenetic studies also showing that chromosomal aberrations in epithelial and stroma elements. Other proliferative changes also can be there along with this. Generally, everybody knows this. There are two types, pericanalicular, intracanalicular. Both patterns can coexist in a single lesion. Pericanalicular means, only one slide about that, that is pericanalicular pattern characterized by stromal proliferation surrounding epithelial elements with open glandular stroma. You can see the open tubule-like areas there. But the intracanalicular pattern in which expansive stroma will be there, that will compress the epithelium and there will be thin curvilinear cords or rim-like stroma will be there. Important fact is this will mimic, or for pathologists it may confuse with phylloid tumor. Another important entity is complex fibroadenomas, which contain proliferative epithelial changes like sclerosing adenosis, epithelial calcifications, then apocrine changes and cyst formation, usually more than 3 millimeter size cyst formation within that. What is the importance of that? This complex fibroadenomas. They are associated with higher risk of continued local growth. And if you are going for incomplete excision, there is slightly increased chance for recurrence, and relative risk for malignancy is high. Actually, 2 times more than the normal fibroadenomas or typical fibroadenomas. Another point that should be there in your mind, we have to rule out or we have to exclude phylloid tumor and fibroadenoma. Phylloid tumor will be associated with more high cellularity and bulky stroma will be there, and there stands for mitotic figures and mitosis. Pleomorphism will be there and ill-defined margins. What is the natural history of fibroadenoma? Usually, they may go up to 3 centimeters, usually up to 25 years. After that, that will stabilize during the reproductive years, then regress with the age or menopause. But some studies shows that around 30 to 35%, 32% cases, there is increased growth of the fibroadenoma. In that case, if a case is there in the clinic, how will you go for diagnosis? Important thing is we have to record clinically the size and nature of the lesion first, because that recording is very important, because all lesions we have to give proper follow-up. Then next investigation is ultrasound scan, which shows well-defined lesion. Classically, they are hypoechoic solid masses. Also, we can identify multiple lesions, follow-up information on growth of fibroadenoma, and accuracy of fibroadenoma in ultrasound is 78 to 99%. The guideline panel of recommends core needle biopsy as a first choice for pathological diagnosis of fibroadenoma, because the accuracy of core needle biopsy is around 93 to 98%. That is not there for FNAC. Then mammogram is the next investigation that is needed. Classical popcorn calcification will be there in elderly age group. Then there are molecular alteration studies are there. Around 60% of cases will be mediated 12 mutations leading to dysregulated estrogen signaling and extracellular matrix. Also, there can be rarer mutation, that is retinoic acid receptor mutation. I'll take 1 more minute. Treatment-wise, conservative management. Most important is reassurance for younger generation between 15 to 25 years, which will include thorough explanation of the natural cause of the fibroadenoma, which will allay anxiety and promote acceptance of the conservative treatment. That is important. That is why all this background knowledge that should be there for the clinicians. So we should be aware about the nature of the disease. Then only we can give proper conservative management. Then there are indications for excision. Then regular follow-up also is needed. What are the indications for excision? When will you advise excision in a case of fibroadenoma, pathologically proved or histologically proved? Age more than 30 years, if non-regressing lesion, then suspicious features like in ultrasound microlobulations and atypia, complex fibroadenoma, size more than 5 centimeters, that means giant fibroadenoma, then rapid growth, family history of breast cancer, and patient preference. Yes. Then what is my rapid growth? There is a criteria for that, Gordon's criteria. According to that, volume growth more than 60% less than 50 years and more than 30% more than 50 years. Also, 6 months duration more than 20% size increase considers rapid growth. Along with increased Brand staging and corneal biopsy showing atypical hyperplasia, then we can suggest excision. One word about VAB, that is vacuum assisted breast biopsy, is safer for fibroadenomas or appropriate size. That means less than 3 centimeters, ideally for less than 2 centimeters. If a large tumor, there is possibility of residual lesions of greater size. Therefore, ultrasound guided vacuum assisted breast biopsy is generally not recommended for lesions more than 3 centimeters. Malignant transformation is very rare. Inside, within the fibroma, it is only 0.002%, 0.0125%. Then epithelial hyperplasia, if it is even then, there is chance for malignancy is less than 7%.
Sorry to interrupt, sir.
One more slide. Follow-up. We have to give proper follow-up. If it is category 3, in our case, Firad's category 3 fibroadenoma, the guidelines plan recommends clinical palpation combined with ultrasound examination every 6 months. And if it is a stable lesion, yearly follow-up is enough. This is the algorithm for a breast mass less than 35 years after confirmed the fibroadenoma. You can go for excision if it is enlarging or more than 35 years. And you can wait for regression. And if it is regressing, follow up until complete regression. And this is for more than 35 years. If more than 35 years, you can include mammography along with other investigations. Confirmed fibroadenoma, you can go for follow-up for 6 to 12 months. If incomplete regression is there, go for excision. If it's enlarging, then again, excision is the treatment. Thank you.
Thank you, Sulfiker. Very nice presentation. The message should be, there is no need for surgery in all cases of fibroadenoma.
Yes, sir.
It is not a tumor. It is basically hyperplasia of a lobule. And therefore, unless it is more than 3 centimeters and continuing beyond 30 years, there is no need for, and more than 3 centimeters, maybe bigger size. Otherwise, no need for surgery. Thank you. Any comments from the floor?
Thank you, sir. Could you move on, please? One last comment, sir.
Sir, I fully agree with you that you should not do anything for a smaller fibroadenomas, but you said there is a role for patient preference.
Yes.
Would you suggest any other alternative methods like RFA or intratumoral injection of ethanol instead of excising the lung?
Recently, studies are there, but not evidence-based. It is not recommended. Level 2 evidence only is there.
Thank you very much, sir.